Welcome to the Human 5.0 Project, the podcast where we cut straight to the breakthroughs that matter, the show where science meets self-optimization. I'm your host, Ultimate Biohacker 10X, and here we break down the real research, real data, and real dosing behind modern biohacking, from compounds and peptides to techniques, devices, lifestyle strategies, and performance protocols. Most people jump in and jump out before they get the gold, so we're keeping it tight and delivering the essential insights you need without the fluff. If you've taken the time to hit play, we'll make sure you walk away with valuable knowledge that can transform your approach to longevity, health optimization, and beyond. Welcome back to the Human 5.0 Project. I'm Ultimate Biohacker 10X, and today we are ripping the mask off of Hashimoto's, the autoimmune condition that quietly affects more than 14 million Americans, mostly women, and always ends with the same script. Your TSH is high. Here's levothyroxine. Forever. But what if the fire starts long before TSH ever moves? What if antibodies are screaming while the labs just look normal? And what if, just maybe, we can put the fire out before the house burns down? Today we're covering the hidden timeline of Hashimoto's, why T4-only therapy fails nearly 60% of patients, the labs most clinicians skip, and the immune, lifestyle, and peptide-based strategies being actively studied this year. Grab a notebook. Let's go. Before we go any further, just a little quick clarity. This podcast is for education, not medical diagnosis or treatment. Autoimmune disease is super complex and highly individual. So nothing here replaces working with a qualified healthcare professional, and anything discussed should be personalized, supervised, and lab monitored. All right, now let's talk about what actually works. The real timeline. Most doctors miss this. Hashimoto's is not a primary thyroid disease. It's an immune attack that can smolder for 8 to 15 years before TSH ever budges. Phase 1, silent autoimmunity. TPO antibodies, also known as thyroid peroxidase antibodies, can be above 30. Thyroglobulin antibodies are elevated. TSH is at 1.8. Free T4 looks perfect. The doctor says, watch and wait. Phase 2, subclinical hypothyroidism. TSH starts to creep to 4, 6, 9. Free T4 is still normal. Reverse T3 climbs. The patient feels exhausted, cold, and foggy, and gets told, you're fine. Phase 3, overt hypothyroidism. The TSH is now above 10. T4 is tanked. Now it's lifelong medication. A 2024 JAMA Endocrinology meta-analysis showed 52% of women with TPO antibodies over 100 progressed to overt disease within 5 years. Translation: waiting for the TSH to break the rules is like waiting for the smoke alarm after the house is already gone. So what do? What do you look for? What labs must you demand? Well, it's the TSH plus reflex. T4 isn't enough for Hashimoto's, so here's the full panel. 6 labs. Your TSH with a goal of 0.5 to 2. Free T4 and free T3, and you want to aim for the top 25% of the range. Reverse T3, goal under 15. TPO antibodies, goal under 9. Thyroglobulin antibodies, goal under 1. Reverse T3 matters because it blocks T3 at the receptor. It's the number one reason T4-only therapy fails. Now, bonus markers that modern clinicians now use: a thyroid ultrasound. A heterogeneous echo means that there's active inflammation. Also selenium and vitamin D, ferritin, and B12. We look at those because deficiencies can actually fuel an immune attack. So you probably got hung up on why only T4 therapy fails. Yes, it's true, and in 60% of patients. So levothyroxine gives you T4, and your body must convert it into active T3. Hashimoto's plus chronic stress, gut inflammation, micronutrient deficiencies, and cortisol dysregulation break the conversion enzymes. So T4 piles up, and reverse T3 spikes. So the patient stays cold, foggy, gaining weight, even on high doses. A 2025 Cleveland Clinic study showed that adding low-dose T3 or even switching to desiccated thyroid reduced antibodies 38% more than T4 alone over 12 months. So this isn't about more hormone, it's about correct signaling. So for a root cause reversal protocol based on data from 2024 and 2025, what do we have? Well, nutrition and inflammation play a big role. So gluten-free and dairy-free for 90 days is a wise way to start. Fisano in 2024 noted that there was up to 88% reduction in TPO antibodies. So for tougher cases, the autoimmune protocol, or AIP, would be wise to look at. It temporarily removes immune triggers while prioritizing nutrient-dense anti-inflammatory foods. What is it exactly? Well, micronutrients such as selenium at 200 micrograms plus myo-inositol 600 milligrams a day. Interestingly, another study by Nordio in 2024 showed that there was a 31% antibody reduction at 6 months by using these methodologies. In addition, vitamin D optimized to 60 to 80 nanograms per milliliter with K2. That'll directly modulate T cell behavior. Regarding gut health, over 70% of Hashimoto's patients have SIBO. The acronym is SIBO. It is small intestinal bacterial overgrowth. They also have dysbiosis or increased intestinal permeability. You really can't calm the immune system until you fix the gut. So that may include treating SIBO, repairing the intestinal barrier, targeted probiotics and prebiotics, and temporary removal of inflammatory foods. So how about stress and the HPA axis? Well, chronic stress definitely raises cortisol. Cortisol blocks T4 to T3 conversion. It also drives autoimmunity. Sleep, breath work, mindfulness, and adaptogens aren't soft. They are endocrine medicine. Also consider low-dose naltrexone, or LDN, at 1.5 to 4.5 milligrams nightly. 2025 pilot data showed that 42% of people with this had antibody reduction, improved T3 levels, and better symptom control. So what about peptides? Are they doing anything in this sector? Well, they are definitely redefining autoimmune thyroid care. They're not thyroid hormones. They don't replace medication. They work upstream. They work at immune signaling, tissue repair, and gut integrity. Thymosin alpha-1, or TA1, which is one of the most studied immune modulating peptides worldwide, retains immune tolerance rather than suppressing immunity. Phase 2 trials for autoimmune thyroid disease are currently underway. Thymosin beta-4, or TB4, is a tissue repair and inflammation resolution peptide. It supports healing of damaged thyroid tissue and reduces chronic inflammatory signaling. BPC-157 supports gut lining repair and immune balance. It's critical because gut dysfunction often precedes thyroid autoimmunity. KPV, another peptide, it's a tripeptide actually derived from alpha MSH. That downregulates inflammatory cytokines like TNF-alpha and IL-6 without immune suppression. It's particularly interesting in early or subclinical disease. Now, this is important to note here that these peptides are adjunctive, clinician-guided, and lab-monitored. They're not FDA approved specifically for Hashimoto's, but the mechanistic data explains why they're being studied. This is where the field is going. Immune modulation, not lifetime symptom suppression. So if we want to create something like a 90-day decision tree, what are we looking for? Antibodies are at 30 to 200. Aggressive lifestyle modifications, micronutrients, LDN, that can show up to 40% remission within a year. Antibodies above 500 or nodules present, well, medication may be necessary, but root cause work often reduces dose needs by 30 to 50%. Retest every 12 weeks. If antibodies drop by more than 50% and TSH normalizes, you may have just dodged the lifetime bottle. Hashimoto's is not a levothyroxine deficiency. It's an immune system screaming for help. Run the real labs. Hit the triggers. Give the immune system an off switch. You can download a free Hashimoto's reversal checklist in the show notes. Stay metabolic, stay curious, and stay autoimmune aware. But before we leave, take a moment to listen to the facts section. Expected pushback. Are you saying people shouldn't take levothyroxine? No, medication can be necessary and life-saving. It replaces hormone. It doesn't address immune cause. Both matter. My labs are normal, but I feel awful. Very common. Antibodies, reverse T3, and immune activity are often missed. Why doesn't my doctor test this? Guidelines focus on TSH-driven disease, not immune-mediated dysfunction. Is this functional medicine hype? Well, some of it is, but immune modulation, gut thyroid signaling, and micronutrient correction are all well documented in peer-reviewed literature. Are peptides safe? I get this one a lot. They are tools, not toys. Some have decades of data, others are emerging. They should always be clinician-guided. Can Hashimoto's go into remission? Yes, especially early. Remission means lower antibodies, less inflammation, and better signaling. Not always zero medication. Who should not try aggressive protocols? Pregnant individuals, immunocompromised patients, those on immune-suppressing drugs, or anyone without medical supervision. Here's a clinician-to-clinician defense. This conversation isn't about rejecting standard of care. It's about expanding it. Current guidelines do an excellent job managing overt hypothyroidism. Where they fall short is in early autoimmune disease, symptom lab discordance, and immune modulation. Hashimoto's patients often present with elevated TPO or TG antibodies years before TSH elevation, impaired T4 to T3 conversion, elevated reverse T3 in the setting of chronic stress or inflammation, persistent symptoms despite biochemical control. These are not fringe observations. They're well documented in the literature. Addressing micronutrient deficiencies, gut integrity, inflammatory triggers, and stress physiology is not alternative medicine. It's systems biology. Regarding peptides and immunomodulators, no one is claiming they are first-line or universally appropriate. They are adjunctive, investigational tools being studied precisely because immune tolerance, not hormone replacement, is the unresolved problem in autoimmune thyroid disease. The position here is conservative. It's not radical. Use medication when needed. Monitor antibodies, not just TSH. Recognize heterogeneity in conversion and symptom response, and accept that immune-mediated disease requires immune-aware strategies. This is not anti-endocrinology. It's endocrinology catching up to immunology, and the patients asking these questions aren't misinformed. They're ahead of the curve. Good medicine doesn't fear nuance. It integrates it. Thanks for listening to the Human Upgrade Project. If you found value in today's episode, share it with someone who's ready to elevate their biology. Make sure to follow the show for weekly deep dives into peptides, protocols, devices, lifestyle strategies, and the science of high-performance longevity. Until next time, stay curious, stay optimized, and stay 10x.